So, hello everybody. It's our pleasure today to have, one of the well-known guests for one of the lectures we have. We've been doing this activity as part of the Sudanese psychiatry group to invite, presenters who are known in the field to help with kind of increasing our knowledge in one areas of psychiatry. Today, we have the pleasure of inviting Dr. Stanely Caroff. Dr. Caroff is an emeritus professor of psychiatry at the Perelman School of Medicine of the University of Pennsylvania. He is recognized as an expert and specialized in neurological aspects of antipsychotic therapy, including neuroleptic malignant syndrome and tardive dyskinesia. Dr. Caroff received his medical degree from the Mount Sinai School of Medicine. He completed his intern and residency training at the Roosevelt Hospital, the State University of New York and Stony Brook, and at the Montefiore Medical Center. And he completed a fellowship in psychopharmacology at the University of Pennsylvania. Dr. Caroff certified by the American Board of Psychiatry and Neurology, and he is a distinguished life fellow of the American Psychiatric Association and a founding member of the Academy of Master Clinicians at the Perelman School of Medicine of the University of Pennsylvania. He received several awards for excellence in clinical care and teaching at the University of Pennsylvania, including the Earl Bond Award, the Blockley Osler Award, and the I.S. Ravden Master Clinicians Award, and the American Psychiatric Association Nancy C.A. Rozek MD Certificate for Excellence in Medical Student Education. He served as a director of the Inpatient Psychiatry Program at the Philadelphia Veterans Affairs Medical Center for over 35 years. He's a member of the board of directors of the Malignant Hyperthermia Association of the United States and serves as a vice president for neuroleptic malignant syndrome information service. His area of research is neurology and psychopharmacology of psychotic disorders. He has published multiple papers that is well known in the field, as well as authored and co-authored and reviewed multiple papers also in the field. We have the pleasure of having Professor Caroff. Professor Caroff, you're welcome to join us today.
Thank you, Yasir, and thank you for inviting me. It's an honor to participate. It's particularly nice to meet Yasir. He's a rising star, I think, in psychiatry and has already contributed important work on catatonia with Andy Francis at Penn State University, and it's an area I'm interested in as well. And I'm sure he's going to continue to do great work in that area. But today, I'm going to talk about a new era in the diagnosis and treatment of tardive dyskinesia, which is another movement disorder that's important in psychiatric practice. Next slide, please. I don't have any financial conflicts to disclose, but the learning objectives for today would be, first of all, to interpret screening policies for the early diagnosis of tardive dyskinesia, or TD, including patient and caregiver reports. Second, to describe the impact of TD on functioning and quality of life. And finally, to talk about an individualized treatment plan for patients who present with TD, including measures of response. Next slide. So what is tardive dyskinesia, or TD? I'm sure you're all familiar with this. It's defined as an involuntary hyperkinetic movement disorder that's delayed in onset and, more importantly, potentially irreversible once it occurs. Now, the symptoms of TD range in phenomenology, severity, and impact. TD mostly affects the orofacial region, about 60 to 80% of patients, but two or more regions of the body can be involved in over half of cases. You have to evaluate and examine the entire patient. TD is mostly mild with an Ames score, total Ames score less than 5 in about 70 to 80% of patients, but it can be moderate or pretty bad, pretty severe with an Ames greater than 6 or more in about 20 to 30% of patients. Now, just as an aside, patients may have tardive dyskinesia but they may have 2 or more different kinds of drug-induced movement disorders in 20 to 30% of patients. For example, in some studies, people with TD can also have tardive dystonia or acute Parkinsonism or akathisia. So next slide, please. So here's a brief listing of the signs or phenomenology of TD. TD most often presents as stereotype movements, which are repetitive, pattern, and pseudo-purposeful, like chewing movements, lip licking, or lip smacking, or choreiform movements that are irregular, random, flowing, dance-like movements like fidgety fingers or toes, or movements of the tongue. But less commonly, but importantly, TD can present as dystonic reactions, which are sustained, pulling, twisting movements or postures like torticollis or blepharospasm, or even akathisia, the restlessness with an urge to move, like difficulty sitting still or leg crossing, and tics and other movements. So these latter movements are less common, but in some cases, they can actually be more severe and difficult to treat. But TD is most often, again, stereotyped or choreiform type movements. Next slide. So if you have a disorder like TD, it can be irreversible. It's important to try to prevent it from happening. So when you're using antipsychotics with your patients, prescribe low risk or low potency antipsychotics at the lowest effective dose for approved indications where you know it can be helpful. It's a good idea to document the rationale for why you chose to use antipsychotics and to educate and warn patients and families about the risk for TD. Now, this may not be possible if you're dealing with a patient who's currently psychotic, but at some point it's helpful to talk to them and ask them to watch for these abnormal movements. It's a good idea to screen people at baseline before you even start the drug for abnormal movements and follow up, have a plan to follow up to detect TD and consider treatments. Next slide. So how often does this occur? How big of a problem is this? Well, they're very good early, extensive epidemiologic studies, mostly with people treated with older first-generation antipsychotics that show that about 3 to 5% of patients treated will develop TD on an annual basis, and it rises cumulatively at that rate. But, you know, although it's calculated and reported as an annual rate, keep in mind that TD may occur actually within a few weeks or a few months in vulnerable patients. So it's not only waiting for 12 months or a year to see this, it can happen much more quickly. The prevalence rate in populations who are treated with antipsychotics shows that about 20 to 30% of patients will have TD at any point in time. But just again, as an aside, I think these figures, as strong as they are and replicated as they are, may actually be an underestimate of the incidence of TD for 2 reasons. First of all, we know that antipsychotics can mask or cover TD, and so the patients are false negatives. And this may occur in as many studies that as many as 34% of patients treated with antipsychotics chronically may actually have TD, and you may not even be aware of it because it's suppressed by the drug. Also, most of the epidemiologic studies have used relatively high diagnostic thresholds. So, for example, they used research criteria to define TD where patients had moderate movements in one area, mild in 2 areas. However, if you considered scores of at least mild movements in one area, the prevalence of TD may increase by 25 to 35%. So TD is actually relatively common among patients treated with antipsychotics. Next slide. So we know that TD, again, the best data we have is that TD occurs in about 3 to 5% of patients treated with older antipsychotics every year. But how long does the risk continue? How long do you have to monitor patients for TD emerging? So this is a graph of early studies by John Kane in New York of the occurrence, the incidence of TD over time. They followed patients for up to 8 years in this study. And it shows that after 8 years, about 40% of the patients had developed TD, which is actually really quite high and disturbing. But what's also important is the slope of the line showing that every year people develop new cases of TD. So the point is that you have to continue to screen for TD emerging at least over several years. It's not just the first year and you can stop looking for it. People continue to develop it over years. And also, if you inherit a patient from another clinician and they've already been treated with antipsychotics for several years and don't have TD, you still have to screen for it because it still may emerge after several years. Next slide, please. Well, the converse question is, how soon are patients at risk? How soon do you have to start watching for TD emerging? And I want to emphasize that TD is not always tardive. For example, in this study, this is a study by a manufacturer comparing the incidence of TD between olanzapine and haloperidol. And it shows, for one thing, haloperidol is about 3 to 4 times more likely to cause TD over time than olanzapine. But more importantly, here again, we're looking at the slope that nearly all the patients who developed TD developed it within the first few weeks or months of being switched to these treatments. So even if you say these emerging movement disorders were unmasked or withdrawal TD or real TD, the point here is that TD can, when you start or switch in antipsychotics, TD can emerge within several weeks. So again, you can't wait for 6 to 12 months to start looking for TD. You'll miss a lot of early cases. Next slide, please. So it's important to know who is at risk for TD, which of your patients might develop this, and this has been studied extensively. Now, the strongest indicator or predictor of TD is older age. Now, this is often stated as, well, TD is most common in elderly patients, but in fact, the data shows that the risk of TD rises dramatically after the age of 40. So even your middle-aged patients have to be watched for TD. So for example, in studies of patients treated with antipsychotics over the age of 45, the incidence of TD is like 3 to 4 times greater than younger people. So it's about 15 to 30% a year will develop TD with a prevalence of 50 to 60%. Now in children, unfortunately, I don't know how it is in other countries, but certainly in the United States, there's increasing use of antipsychotics in young children. And TD, the risk of TD in children is less well studied, but still it does occur, the prevalence of 8 to 20% with an incidence about 0.3 to 0.4%. And there's another related phenomenon. Young children treated with antipsychotics can have a withdrawal emergence syndrome, kind of a generalized chorea developing in children who are taken off antipsychotics. So it's important to watch even in children if you're using antipsychotics for TD. The risk is probably less than in adults, and children are probably more likely to show recovery from TD when withdrawn from antipsychotics. There are data that maybe older women, and there are racial differences in the risk of TD, and different psychotic disorders may have risk of TD. There's some data you may read about diabetes and medical comorbidities being at risk for developing TD. But in fact, as you know, diabetes and weight gain are risk factors with long-term use of antipsychotics by themselves. So it's not that diabetes is a risk factor for TD, perhaps. It may simply be another comorbidity, a risk for long-term antipsychotic treatment. Now, there are some preliminary study of genetics to try to find out if people with certain genetic abnormalities might be more at risk for TD, but the results are not consistent and not currently practically useful in practice. Now, some people think there's a sort of conventional wisdom that TD is somehow restricted to people only with chronic mental illness like chronic schizophrenia, but that's not true. TD is not just something that people with chronic illness develop. Next slide, please. Now, treatment factors that increase TD risk, which antipsychotics are high risk for TD. We know that there's pretty good data that older so-called first-generation antipsychotics, more potent antipsychotics, are more likely to cause TD than newer or less potent agents, second-generation agents, both in incidence and prevalence. So second-generation drugs are probably less likely to cause TD, although they're used more frequently, at least in the United States. And so the absolute number of patients who might develop TD remains large. Now, you might think that people who get injections with long-acting antipsychotics might be at greater risk for having TD because they have antipsychotics in their body all the time. But in fact, the data suggests the opposite, that the risk with long-acting injectable agents is no greater than oral agents. In fact, the data suggests that people who are treated with oral antipsychotics and frequently non-adherent, they go on and off the antipsychotics, are actually more likely to develop TD than people who get continuous treatment with injectable medications. There is interesting research of antipsychotics that don't affect the dopamine 2 receptor by a number of novel mechanisms, and they may actually be able to treat psychosis without any risk of TD. So it's important to watch this research and see if any of these drugs come to market. Patients who receive higher doses, longer treatment with antipsychotics at risk. People who develop acute extrapyramidal problems like Parkinsonism or akathisia probably also at risk for TD. And people who get anticholinergics like benztropine or others are said to be at risk for TD, but actually anticholinergics themselves make TD worse. So if a patient has TD or subtle TD, if they're treated with benztropine or other anticholinergics, it'll make the TD more obvious and worse. But anyway, with all of this in mind, it's a little complicated. I think the take-home message for people in practice is that anyone prescribed any antipsychotic for any condition for any sustained length of time is at risk for developing this reaction. Next slide, please. So how do you screen for TD? There are standard scales that you could use. The abnormal involuntary movement scale or AIM scale is the gold standard. If it's a very good, brief, objective scale. It has 12 items, but really only the first 7 are what are best validated, covering different areas of the body. And you can rate whether people have abnormal movements by amplitude, frequency, and duration. Now, the old guidelines suggested that you do a formal AIMS examination every 6 to 12 months, but now, fortunately, the APA guidelines have been modified to add that you should screen patients basically for abnormal movements at every clinical visit, at least every 3 months. So, as part of your interview of a patient, when you see them in the clinic, you always ask for if they have any side effects. And, looking for tardive dyskinesia is part of that. And you should ask every time you see the patient on antipsychotics. And it's a good idea to inform patients and caregivers to self-examine and report any new abnormal movements. Next slide, please. Just briefly, if you're using telehealth or you're very busy and you don't have time to do a complete AIMS exam, there are a number of abbreviated ways of doing this. There are so-called mind questions. You basically ask the patient if they've noticed any abnormal movements and how it affects them. And then in the context of your mental status exam, you can briefly have them hold their arms out in front of them and distract them by counting backwards from 100. Ask them to open their mouth, protrude their tongue while tapping their fingers, and watch them when they're coming and going from your office to see if you can pick up any abnormal movements, and then you can document them. Next slide, please. Now, in addition to assessing the severity of someone's abnormal movements, it's in terms of deciding whether you need to treat them or do anything about it. It's also important to ask patients and their families how do the movements affect their lives and whether it's important enough to intervene with treatment. So in terms of awareness, it's interesting that even normal people are often unaware of mild tics and habits. This is even worse in people with schizophrenia who have generally limited insight about their bodies and bodily functions. Now, early studies sort of bias this by studying mostly chronically ill patients who were incarcerated in long-term institutions. And that kind of left the conventional wisdom that patients generally not aware of TD or it doesn't bother them. But in more recent careful studies, up to 75% of patients who had TD actually were aware of it and were generally embarrassed by having TD. Even mild TD results in stigma that can affect employment, dating, and friendship in an interesting study that was done. And it can affect quality of life. Generally, there's an association between TD and more psychopathology, lower functioning, impaired cognition, impairment in activities and productivity. And patients with TD, probably because they're older, have more medical problems as well. So, TD can range, again, from being so severe that it interferes with physical functioning, like walking and speaking and eating and so forth. But even mild TD can really be catastrophic to a more functional patient. Someone who's teaching or professional, if they have even mild movements, as you know, it can be very stigmatizing and embarrassing. So the take-home message here is even mild cases of TD can significantly affect quality of life, and we need to ask patients about its effect on their lives. Next slide, please. So here's just two examples of how TD might interfere with life. A mother reports her daughter developed orofacial movements after receiving aripiprazole for a first episode of mania. She was embarrassed and stigmatized. She stopped going to school, stayed in a room, became depressed and suicidal, which is very unfortunate. And this could be corrected by possibly tapering her off aripiprazole and treating her mania with mood stabilizers. Or if that's not a success, we can even treat her with one of the new VMAT2 inhibitors that we'll get to in a minute. Another young man was treated with long-acting paliperidone or haloperidol for schizophrenia and developed chewing and tongue protrusion, but wasn't bothered by it. However, he was unable to attend group sessions in a rehab program because the other members of the group complained about his mouth movements. And here again, you don't want to change the paliperidone if he's doing well, but you could treat and really suppress his tardive dyskinesia with VMAT2 inhibitors. Next slide, please. What about diagnostic criteria for TD? This has been well studied. You're probably familiar with the research criteria by Nina Schooler and John Kane several decades ago. That's really been the gold standard in psychiatry and in studies. And those criteria require a 3-month exposure to the antipsychotics, an AIM score greater than moderate or greater in one area, or mild, rated 2 in 2 or more areas, and to be persistent, being present for greater than 3 months. However, experts will argue that in a way, there's really no lower limit for diagnosing TD in a person. So we won't go through the other criteria that are out there. Again, Schooler Kane are really the gold standard. However, in your private practice or in your practice, I think even take-home message at the bottom, even mild movements in one body area. So for example, if patient has fidgety fingers or chewing movements alone, that developed after 1 month of exposure to antipsychotics, if it's still there after 2 visits, that's probably indicative of having TD. So I think the threshold for diagnosing TD in your clinical practice is probably lower than the research criteria. Next slide, please. Well, TD has a differential diagnosis. Other diagnoses should be considered if you see abnormal movement. So even 100 years ago, Kreplin and others recognized these types of movements in patients with schizophrenia. So we know from studies that 5 to 15% of patients who are antipsychotic naive who have schizophrenia may also have orofacial or other peculiar movements. And about 1% of older people in the community and 5% in care homes may also have orofacial movements. So that's a common differential diagnosis you have to consider in TD. And also importantly, acute reversible drug-induced movements from other drugs. So I'm sure you know that antipsychotics are great imitators. They can cause dystonia, Parkinsonism, tremor, and akathisia that can be reversible once the antipsychotics are stopped. And other drug classes like lithium, antidepressants, anticonvulsants, stimulants, and withdrawal syndromes can also present with abnormal movements. So these have to be considered before you conclude someone has TD. And finally, there's a long list, of course, of medical neurologic disorders that can present with abnormal movements. And clues to that would be if someone has an unusual presentation or an unusual course, or they have a family history of movement disorders, or if they have abnormal laboratory results or imaging studies, you have to consider other rare conditions and maybe get movement disorder specialists or neurologists to help you figure that out. Next slide, please. And here's an example. It's very important to differentiate TD from drug-induced Parkinsonism because the treatments are quite different pharmacologically. So TD is hyperkinetic movements that we talked about. You know, Parkinsonism is more slowed or hypokinetic movements and tremors. TD is persistent after the drugs are stopped, whereas Parkinsonism in most cases will subside if antipsychotics are discontinued. And at the bottom, you can see pharmacologically the differences in responses. So, you know, if you start or increase antipsychotics, they will suppress TD, but they will make Parkinsonism worse. If you stop or reduce antipsychotics, TD may initially get worse, but may improve over time, whereas if you stop the antipsychotic, Parkinsonism will get better. Similarly, there are differences in how TD and Parkinsonism responds to anticholinergic drugs. So Parkinsonism, anticholinergics are a very good treatment for drug-induced Parkinsonism, but they make TD worse. And the VMAT2 inhibitors that we'll cover in a few minutes suppress TD, but they make Parkinsonism worse. And I won't talk much about amantadine, except that may be a very good alternative to antipsychotics in Parkinsonism, may actually make TD better as well. So you can see that drug-induced Parkinsonism and TD are treated very differently, and their responses to treatment are very different. So it's very important for you to be able to distinguish Parkinsonism from TD. Next slide, please. So let's move on to treatment. What's an effective treatment plan if you see TD in a patient? Well, you should document the severity distribution phenomenology and probably do a formal AIMS scale that you can record. Question the patient and families about the awareness of TD and whether it affects their self-esteem and functioning. It's a good idea to document that you discuss TD and its treatment with the patient. And then reassess antipsychotic and anticholinergic treatments. And finally, if you have VMAT2 inhibitors available in your center, consider VMAT2 inhibitors for moderate, severe, or disabling TD, but also for mild TD if it really impacts the patient's quality of life. Next slide. Well, you know, antipsychotics are probably the most powerful suppressor of TD and abnormal movements, but they're generally not recommended as a treatment for TD because they also cause it. However, when you're treating someone with any medication, let's face it, or with antipsychotics, and they develop a serious side effect, could be weight gain or diabetes or sedation, you're really obligated to reconsider the antipsychotic treatment. And that's true, I believe, for TD as well. It depends on the patient's condition. So let's go through a few scenarios. First of all, if you have a patient with a psychotic disorder like schizophrenia and they also have TD, but they're doing very well on your treatment, and TD doesn't bother them, perhaps. So there you may decide in many cases to just continue the antipsychotic and just simply monitor them for TD, although you have to probably discuss your observations with the patient. But let's say the same patient is bothered by their TD, and there you can maintain the antipsychotic at the current dose, but you can also add a VMAT2 inhibitor to suppress the TD. And the studies developing the VMAT2 inhibitors showed that they were very well tolerated in combination with the patient's regular antipsychotic regimen. Now, you may see that some guidelines suggest reducing the dose of the antipsychotic as a treatment for TD, but there's really not good controlled evidence that works. Actually, when you lower the dose of antipsychotics in someone with TD, it may actually initially get worse, and certainly you risk relapse of their psychosis. So reducing the dose of antipsychotics is not really probably reasonable intervention. Next slide, please. So here's an example where it's important to maintain the antipsychotic even in the face of someone with TD. A 59-year-old man with schizoaffective disorder is doing quite well on perfenazine, but has chewing, lip licking, and tongue protrusion. Although he's embarrassed by this, he's coped with it for many years. However, a new doctor sees this as alarmed and discontinues the perfenazine. Not only does the dyskinesia worsen, but the patient suffers a psychotic relapse, has to be admitted to the hospital in restraints. He develops phlebitis and a pulmonary embolus because he's rigid and restrained, and he has to be transferred to a critical care unit, nearly dies. Now, this all could have been avoided, of course, that since the perfenazine was working, you should maintain it. It's effectively treating a schizoaffective disorder. And then you could, again, add a VMAT2 inhibitor to suppress the TD if the patient wanted that. And here, the takeaway that I'll emphasize again and again is that people with schizophrenia spectrum disorders or psychotic disorders are very high risk of relapse after antipsychotic discontinuation. Next slide, please. Well, here's another scenario. Let's say you have a patient with psychotic disorder like schizophrenia, and they also have TD, but they're not doing well, and you really need to switch their antipsychotic. What would be the effect on TD? Well, if you switch to another or a first generation or more potent antipsychotic, that may actually suppress the TD in up to 2/3 of patients, but it risks acute extrapyramidal problems and may limit remission. If you switch them to a second generation or less potent drug or a different SGA, most likely the TD will continue in the same course of being persistent and fluctuating, although studies show actually there's a reduction in the mean scores. So if you switch someone to an SGA or another SGA, probably TD is just going to continue as it has. Although there's some suggestion or thoughts that clozapine is particularly helpful in people with schizophrenia and TD, may decrease TD up to 80% of patients. And so clozapine, as you know, is probably, well, it has other problems like agranulocytosis and many other side effects. But a patient who has treatment refractory schizophrenia, or if a patient has refractory TD that doesn't respond to VMAT2 inhibitors or other interventions, a switch to clozapine might be a reasonable thing to consider. And if the patient has been non-adherent and you want to switch them to an injectable long-acting antipsychotic, of course, you would choose a second generation or a newer form of LAIs. but most likely the TD will continue to be persistent and fluctuate after the switch to an injectable drug. Next slide, please. So just quickly here, I want to show two examples of switching drugs. This is the CATIE study in the United States that involved randomizing patients to one of the four antipsychotics shown on the graph. And this is a subgroup of that study, that 200 patients who had TD at the start of the study and were randomized to these drugs. And there was no difference between the drugs, but overall the TD on average decreased during the time of the study. The majority of the patients, 76%, continued to show TD at some or all of their visits, but about a quarter of them did not show TD in any visit. So it was completely suppressed by a switch to these different drugs. About a third of the patients showed a significant decrease in scores, and about 7% showed an increase in the score. So again, switching to SGA is not going to harm TD and probably diminish it in some patients, but for the most part, TD will continue to be persistent. Next slide, please. Here's an older study by George Simpson in the United States showing that switching patients with TD clozapine suppressed the TD over the period of a few months, but when the clozapine was stopped, the TD just recurred. So clozapine is probably pretty good at suppressing TD, but so are many of the other antipsychotics. But switching to other drugs for other reasons, like a non-response, non-psychotic response to antipsychotics, is certainly something that ought to be done. And the effect on TD is, if anything, probably beneficial. Next slide, please. The final scenarios, let's say you have a patient with a non-psychotic disorder, PTSD or borderline personality or depression, and they had received an antipsychotic and developed TD. What is the effect if you decided they don't need the antipsychotic and you wanted to stop it? Well, there are older studies, mostly with first-generation agents, that studied this, the effect of drug withdrawal on TD. So, for example, Glaser, in a well-known study, stopped TD in patients, and about a quarter of them had a 50% improvement in TD, but only one person off the antipsychotic showed disappearance of the TD completely. On the other hand, a quarter of the patients with mood disorders relapsed, and 50% of the patients with schizophrenia with one suicide relapse. Zucchi and a movement disorder clinic showed that about 13% of patients who were taken off antipsychotics showed complete remission in TD over 2 to 3 years. And finally, Stanely Fawn showed, after stopping the antipsychotic, that there was remission in about 2/3 of the patients with mild TD. So he showed that in a number of patients, stopping antipsychotics actually reversed the TD with mild TD, although the results were less impressive in people with moderate to severe TD. Only about a fifth of the patients showed a reversal. But here again, the patients with schizophrenia did badly off antipsychotics, as you might imagine, and 3 of them relapsed within a few months. So what's the take-home message here? To be honest, we really don't know whether stopping the antipsychotic in patients with TD who don't have psychotic disorders results in remission. Especially, there aren't very good studies with second-generation agents. Most of the data is older with first-generation agents. It may be that people with mild TD, or if you can catch TD early when it first starts, or younger patients, may have a greater chance of reversing and remission from TD over time if you're able to stop the antipsychotics. But the important message also is, if you have a patient with schizophrenia or severe psychotic disorder, the relapse rate is way too high in terms of risk to stop or reduce the antipsychotic. Finally, withdrawal dyskinesia, you should be familiar with that some people have a dyskinesia or abnormal movements that emerge after you stop antipsychotics for other reasons. And by definition, that resolves spontaneously within a few months. That probably is an early risk factor for true persistent TD, but in people with these withdrawal dyskinesias may not require treatment, and patients could be reassured that it may resolve spontaneously. Next slide, please. What about anticholinergics? Anticholinergics are very effective for acute dystonia and Parkinsonism, but they don't seem to work for akathisia or TD, which they actually make worse. They're unfortunately used at excessive doses without proper indications, and they have significant side effects that you should be familiar with, especially in older adults. There really isn't evidence that anticholinergic drugs reduce TD. In fact, as I said, anticholinergics actually can worsen TD, make it worse. And if you taper it off, there's some data that TD actually improves in 60% of patients. However, as we talked about before, TD often occurs with other movements like Parkinsonism in the same patients. So if you taper off anticholinergics, you might get a cholinergic rebound or really a reemergent or worsening of acute dystonia or Parkinsonism. Just to make matters more complicated, I don't want to confuse you, but anticholinergics may be effective in up to half of patients with tardive dystonia, and tapering may lead to worsening. So people with dystonic movements related to TD actually are helped by anticholinergics, get worse if you taper it off. Next slide, please. So very quickly, I don't have much time, but we want to talk about vesicular monoamine transporter 2 inhibitors, or VMAT2, which really deplete dopamine in the presynaptic nerve terminals. So this is a pretty crude diagram. I apologize for my lack of artistic talent, but there are vesicles in the presynaptic terminal that absorb dopamine in the cytoplasm and protect it from being broken down. And the dopamine and other neurotransmitters are transported into these vesicles by a transporter, VMAT2. So if you inhibit it, dopamine is going to be broken down. There isn't dopamine in these storage vesicles to be released in the synapse. So there's less dopamine, and less dopamine translates into reduced abnormal movement. So any drugs that can deplete dopamine by inhibiting VMAT2 transporter will result in reduced movements of tardive dyskinesia. Next slide, please. And we've known this for many, many years because of tetrabenazine that you may have available in your country. Tetrabenazine was synthesized, I guess, in the 1960s or 50s as a better antipsychotic than reserpine, which was an irreversible VMAT2 inhibitor. So tetrabenazine was approved as an antipsychotic, but early on it was known to be effective in reducing chorea. It's been used off-label for suppressing TD, although it's not licensed or approved for that indication. You can get moderate to marked improvement in TD in up to 40 to 90% of patients with TD, but it has limitations. It has a very short half-life, so you have to give it frequently during the day. And it has a high risk of side effects like depression, suicidality, sedation, Parkinsonism, QT prolongation, such that genotyping is required in patients who you want to put on higher doses. So tetrabenazine is very effective for suppressing TD, but it does have these shortcomings. Next slide, please. So a number of groups tried to improve the molecule of tetrabenazine and make it more usable. And one group synthesized valbenazine, which is slowly metabolized to one of the four main metabolites of tetrabenazine. And the metabolite that it's changed into in the body is very high affinity for this transporter and virtually no off-site binding. So valbenazine is a long-acting drug relative to tetrabenazine. It's very specific for the transporter and doesn't affect other receptors, so there aren't as many side effects as tetrabenazine. Next slide, please. So the value of valbenazine was really well studied in very rigorous state-of-the-art randomized controlled trials that are listed here, a variable dose study, a fixed dose study, on an open label year-long study, all of which showed that valbenazine was significantly more likely or decreased tardive dyskinesia more significantly when compared to placebo. And there were really no signals that it had any dangerous side effects. So it was licensed in the United States as a treatment specifically for tardive dyskinesia and Huntington's chorea, I believe. Next slide, please. Now, another group tried to improve tetrabenazine by replacing hydrogen in the molecule of tetrabenazine with deuterium. And by replacing hydrogen with deuterium, you have a much stronger, stable molecule. So while tetrabenazine rises rapidly in the body, has a very high peak level, which results in a lot of side effects, and it's metabolized very quickly, so you have to dose it frequently. By comparison, tetrabenazine has a very delayed and reduced peak concentration with slower metabolism. So you have fewer side effects and a longer half-life. So you only have to give it once or twice a day. Next slide, please. So tetrabenazine was also studied in rigorous state-of-the-art controlled trials, listed here, a variable dose study, a fixed dose study, and a long 3-year extension study, which again showed that tetrabenazine resulted in a significant reduction of the abnormal movements of tardive dyskinesia compared to placebo, especially at the higher doses. Next slide, please. So prescribing these drugs, if you do have them available, certainly you can use tetrabenazine, which does work. But if you have these newer drugs, they're very easy to use. Valbenazine is given 40 milligrams a day for a week, and then it can be increased to 80 milligrams if tolerated. Tetrabenazine, there's now a longer extended release form, so that also can be given once a day, 12 milligrams, increased by 6 milligrams a day each week, up to 48 milligrams. And you can see the differences below that. You have to consider if the patient has hepatic impairment, their potential drug interactions, mostly with CYP2D6 cytochrome enzyme, or if you use other drugs that inhibit these enzymes, you have to keep the dose of both drugs lower. In terms of side effects, most commonly they cause sedation or somnolence. They can cause or worsen Parkinsonism or akathisia. They're not by themselves probably not likely to result in dangerous QTC prolongation, but you have to be aware if the patient is genetically at risk for QTC prolongation, or they're on other drugs or have other conditions that can make the risk of QTC prolongation more likely. In using them, I think you should titrate to maximum efficacy if the patient tolerates it, and a reasonable trial is something like 6 to 12 weeks. There aren't any head-to-head studies of valbenazine, tetrabenazine, or tetrabenazine. So we don't really know or have any data as to which is so-called the best treatment for a particular treatment. We know certainly valbenazine, tetrabenazine has been proven to work. They both work effectively. They have similar side effects. And now, since tetrabenazine has an extended release form, they can both be given, reasonably in terms of frequency of dosing. Probably the only difference for you is valbenazine is very easy to titrate. You started actually at a therapeutic dose. 40 milligrams a day is the starting dose. That has been proven to be effective for tardive dyskinesia. So you're already effective within the first week or so, and if the patient tolerates, you can increase it to a maximum dose very quickly. do tetrabenazine, the way the titration schedule was approved for use is a much slower titration schedule. You start them at 12 milligrams a day, but we know 12 milligrams is not a therapeutic dose. So it may take 2 or 3 weeks or more before you get up to a therapeutic dose. Now, that's potentially a disadvantage if you want to get a therapeutic dose quickly. On the other hand, if you have a patient who's sensitive to the drugs and has side effects, or is older or something like that, it's actually helpful to be able to titrate at smaller increments and take your time titrating it upwards. Next slide, please. Very quickly, people have considered what's the best measure for a successful response. There are a number of statistics in the studies that show these drugs are more effective than placebo in these population studies. There's about a 30 with both drugs. There's about a 30% decrease on average in severity scores, and about a third of the patients show a 50% or greater improvement in AIMS. But an individual patient in your practice, from the studies, we know that if the patient can achieve about a 3 to 4 point decrease in their AIMS scale with one of these drugs, or if they can decrease their total AIMS score by 30 to 40%, they generally reported feeling much improved or very much improved. So in your practice, if you're using the AIMS scale, if you can get them down to a 30 to 40% improvement in their score, they generally feel much better. Next slide. I'll try to quickly finish. If the VMAT2 inhibitor fails, you should recheck the diagnosis. You could try a second VMAT2 inhibitor if one doesn't work. There's really not great evidence, or there's conclusive evidence on other drug treatments of TD. Some studies suggest clonazepam, which probably has a non-specific anti-anxiolytic effect, but that has side effects, especially in older patients, cause sedation, ataxia, cognitive impairment. It could be abused. Vitamin E or other antioxidants has not had convincing efficacy data. In a big VA trial, we found it was no better than placebo. And vitamin E and other nutritional supplements are not really regulated closely by the FDA. Amantadine really isn't proven. There are few underpowered trials, but amantadine may have a special place as treatment in patients who have both TD and Parkinsonism. We won't go into the complexities of treating a patient like that, but amantadine may be effective in both of those studies. Finally, there are TD subtypes like dystonia again, or tardive akathisia. And here, there isn't great data, but from early studies, the VMAT2 inhibitors like tetrabenazine and the newer ones are probably the first-line treatment, but in tardive dystonia, clozapine, anticholinergics, botulinum toxin, neurosurgery might be considered if it's severe. And tardive akathisia really hasn't been studied in and of itself, but perhaps propranolol, mirtazapine, B6, which have been effective in acute akathisia, could be studied in that as well. Last slide, please. So just very quickly, again, any patient on any antipsychotic for any condition, any sustained length of time is at risk for TD. TD ranges from mildly embarrassing to painful, generalized movements that can be stigmatizing, incapacitating. You have to really ask the patient to what extent they're bothered by TD as to whether or not you choose to treat it. And effective management, screening, documentation, discuss it with patients, reassess psychotropics, and consider VMAT2 inhibitors. And the final slide. Thank you. There's no funding, no conflicts, no acknowledgement. So thank you very much for listening. I hope this talk was helpful, and I'm open to any questions you may have. Thank you very much.
Thank you very much, Dr. Caroff, for this very valuable presentation. We have some questions here. Dr. Francis, you can ask your question.
Thank you, Stan. Excellent talk. While I'm skeptical, our young trainees believe that a variety of antipsychotic drugs are quote unquote mood stabilizers. Are we headed for an epidemic of TD?
Wow. Yeah. Good. Really excellent question, Andy. And I share your concern. Absolutely. I think that the explosion of prescribing of antipsychotics and the resulting polypharmacy is concerning. I think there is evidence that, certainly, as you and I know, and others who've been in the field for a long time, antipsychotics were always helpful in treating someone with acute mania until lithium or other mood stabilizers kicked in, and then we tried to taper them off antipsychotics to prevent TD. I'm sure you'd agree with me, but I understand and think antipsychotics may be useful in people with bipolar disorder, especially if they're relatively refractory and psychotic and have repeated episodes. But I'm not sure that that justifies the explosion of prescribing of antipsychotics for mood disorders, depression, especially. Again, we always used antipsychotics for depression with psychotic features, but as a maintenance drug, not so great. And I'm concerned, as you are, that the prevalence of and wide use of antipsychotics for other indications and for unproven or off-label indications is unwarranted and can cause a lot of side effects, weight gain, diabetes, and so forth, and TD as well. So I think your concerns are well taken, and we are concerned, even though newer antipsychotics, as I said, are less likely proportionally to cause TD than the older first generation antipsychotics. The fact that they're more widely and frequently used means that we're going to continue to see TD occurring in people who may not have needed antipsychotics in the first place. Thanks for the question. Good point.
Thank you. Actually, I have a personal question myself before I go to some of the questions in the chat. So I came across the evidence by the American Neurology Association, I think guidelines in 2011, 2012, talking about the evidence for medications used for treatment of TD. At that time, the VAM inhibitors were not in the market yet, but they recommended two medications. One of them was clonazepam, as suggested in the presentation, but the second one was ginkgo biloba, which is not familiar with exactly what is the, how does that work?
Yeah, that's a very good point. The neurology folks came out with the meta-analysis and guidelines. But you have to understand that they really based that on the quality of the controlled studies, which is legitimate. Whether there was sufficient quality evidence to prove one thing or another. But that, in my opinion, that's not a practical guideline. We can talk about the quality of the studies, and that's very important to do from a scientific point of view. But in terms of a clinical practice point of view, clonazepam is a good example. There are very, very few limited studies. So by, standard criteria, it meets maybe a higher level than case reports for possibly being helpful in TD, but it's not proven. But more importantly, clonazepam would be a very difficult drug to use for tardive dyskinesia in many patients. Again, it probably has a non-specific effect. Anything that calms a patient, reduces anxiety, is probably going to reduce abnormal movements. Patients with abnormal movements, including TD, if they're quiet and calm and they go to sleep, the movements disappear. Whereas if they're activated or anxious or restless, the movement's going to be worse. So something like clonazepam or any other benzodiazepine that calms the patient will reduce the TD non-specifically. So it's not a specific treatment for TD. On the other hand, the side effects are significant. So again, you wouldn't give clonazepam to a 75-year-old patient. They'll fall, they'll hurt themselves, and so forth. And younger patients may abuse it. So, although the studies may have some degree of quality in showing efficacy and safety in a clinical practice, it certainly can be used, but it's not, in my opinion, certainly with the VMAT2 inhibitors on the market, it's not a first-line agent. Ginkgo biloba, it's a beautiful tree, by the way. Ginkgo biloba trees are beautiful in the fall. They turn bright yellow. But it's a nutritional alternative treatment. It's not well regulated. There are, again, the quality of the studies, as far as we know, have some value compared to case studies and limited evidence. But I'm not convinced. I believe it works perhaps as an antioxidant, but in my opinion, the data is not conclusive. It's certainly not approved by the FDA as a treatment for TD. So I'm not sure that the efficacy is shown. And since it's not a regulated product, I'd be reluctant to tell patients, although I'm not against alternative treatments and self-help treatments and nutritional treatments and so forth, I'd be a little reluctant to tell someone with significant TD, just go to your local health food store and pick up something. That's my personal bias. But certainly compared to the VMAT2 inhibitors, it doesn't calculate as effective. So that's a very good question. I'm glad you brought it up about the neurology guidelines. Again, they're good scientific analysis of this quality of studies, but they're not directly useful, I think, in clinical practice. And the follow-up a revision of those guidelines recommend VMAT2 inhibitors as the first-line treatment for TD.
Right, thank you. I have a couple of questions here. So what is the common presentation of TD in children?
Well, again, I don't work with children mostly, but the literature suggests that it's similar to adults. But in addition, because of their age and maybe because the antipsychotics are not used as long-term, children may have a better chance of remission of TD if the drug is stopped. On the other hand, this phenomenon described in the literature of withdrawal emergent syndrome, which is a more generalized chorea that could be quite alarming to families. But the data suggests that the prognosis is very good even for those children, that it could resolve. So TD may be less likely to occur in children, perhaps because the way antipsychotics are used, but fortunately, on the other hand, they may be more likely to remit. I would just add that children, like with hyperactivity disorders and so forth, often wind up on stimulants. And you should keep in mind that stimulants themselves are a well-known cause of hyperkinetic abnormal movements. So if you have a patient who's on antipsychotic and a stimulant, and they develop abnormal movements, it may be due to the stimulant as much as the antipsychotic. But that's a very good question. If you're a child psychiatrist, I'd suggest looking into this. As really a need for better studies of TD in children. And back to Andy Francis's question, unfortunately, I think antipsychotics, the newer antipsychotics, are being used much more widely in young people and children, off-label, and I think that's a concern.
Right. Thank you very much. Two more questions. A question from Dr. Lubna. Thank you for your precious lecture. There were recommendations in switching from first-generation antipsychotic to second-generation antipsychotic with less D2 affinity in literature previously. So isn't it preferably than decreasing or stopping the antipsychotic?
Well, I don't think we have data to compare one to another. I think if you lower the current antipsychotic or you switch them to another antipsychotic, in both instances, you run the risk of worsening psychosis, and so that's a prime consideration. But if you have other reasons to switch the antipsychotic, that might be certainly a reasonable thing to do, to switch them to an second-generation antipsychotic from a first-generation antipsychotic. But we don't have great data that the tardive dyskinesia will be treated as effectively as a VMAT2 inhibitor. It's something to try and consider, but you always run the risk of worsening psychosis, so it has to be done carefully.
Thank you. One more question here. Thank you so much. This is a comment. When doctors tried to stop antipsychotics completely for one patient who was on 5 milligrams of aripiprazole, he developed tardive dyskinesia. Then they decided to put him back on the aripiprazole, and tardive dyskinesia disappeared. Do you think if they had waited longer without the medication, it would have stopped, would stop? And if yes, for how long?
Yes, that's a very good question, and you're correct that if the dyskinesia is only seen after the drug was stopped, it could be withdrawal dyskinesia, and if you're able, you could keep them off the antipsychotic, and it might resolve over time, but there isn't great guidance about how long that would take. As I pointed out in at least some of the earlier studies with first generation drugs and people who had treated chronically, it could take months or even a few years for tardive dyskinesia to resolve. So, I think if the patient's showing signs of a relapse of psychosis, obviously you have to restart them on the antipsychotic. Or if they can't tolerate being off the aripiprazole, they can't tolerate the tardive dyskinesia because it's embarrassing or it interferes with their life, you could restart them on aripiprazole, as you said they did, to just simply suppress the dyskinesia. Or fortunately, nowadays, you could, instead of restarting the antipsychotic, if they don't need it, again, if they don't have schizophrenia or something like that, and they just were on the aripiprazole off-label or for no clear indication, but if you don't, nowadays you can actually replace that by giving them a VMAT2 inhibitor, which would simply suppress the tardive dyskinesia, and then possibly, we don't know this, but possibly over time, off of a dopamine receptor blocking antipsychotic, perhaps the tardive dyskinesia will resolve while simply on a VMAT2 inhibitor suppress it. I don't know if that's clear, but although restarting them on the aripiprazole to stop or suppress TD if they can't tolerate it and interferes with their life may be something you have to do with the patient's consent. On the other hand, the VMAT2 offers an alternative where you can keep them off the antipsychotic, use a VMAT2 inhibitor dopamine depleter to suppress TD so the patient's comfortable. And maybe over time, off of aripiprazole, the tardive dyskinesia will resolve on its own, and you can taper off the VMAT2 inhibitor. That's speculative, but it's an alternative to restarting the aripiprazole.
A couple of comments about thanking you for the fruitful and comprehensive lecture. Just one comment from Dr. Hamad Ibrahim. He's a psychiatrist in Sudan, talking about his clinical experience. According to my clinical experience, about 25% of my patients with TD have persistence of symptoms when antipsychotic drugs were withdrawn.
Yeah, thank you for your comment. Again, it's an honor for me to participate in this session, but you said that 25% of the patients continued to have TD or showed remission.
No, continue to have TD, I think, after antipsychotics were withdrawn.
I see. So 75% of the patients showed improvement or resolution. Well, that's great. That's very positive data. And, congratulations to you for probably recognizing it swiftly and following the patients and treating them by alternative means until the TD went away. That's what we would like. That in a way, that's what we would like to see. Although for people clinicians in general, you have to be concerned. If the patient has schizophrenia or some chronic psychotic disorder, the great concern is, of course, watching for or risking a psychotic relapse, which is the worst possible outcome.
I have more questions if you have time, Dr. Caroff.
I just have a few minutes, but sure, go ahead.
So can we differentiate between tardive dystonia and tardive dyskinesia? And the second one, affective symptoms and tardive dyskinesia.
The tardive dystonia, there are problems with the semantics, and this is being discussed a lot. Whether tardive dyskinesia covers all the abnormal movements and all the variations, or tardive dyskinesia, the term itself, is restricted only to the orofacial, classic oral buccal masticatory movements of the mouth and face. But having said that, tardive dystonia, you have to be able to recognize dystonia, which is a very different movement than stereotypies or choreiform disorders. And so, yes, clinically, you can distinguish those two. In terms of the treatment at this point in time, I would say that the treatment, if it's indicated and the patient wants it, the treatment is the same, VMAT2 inhibitors. But there is a lot of data on tardive dystonia that the prognosis is different, that it tends to be more severe, more generalized, more likely in younger patients than older patients, and the prognosis is worse. So there are differences, whether it's a different disorder or it's really just a different variation of tardive dyskinesia, it's not clear. But you should be able to recognize, document it, but still the treatment may be the same. There was another part of that question.
Affective symptoms and tardive dyskinesia.
I'm sorry, affective symptoms?
Yeah.
That's a very good, very interesting question if I understand it correctly. You know, akathisia is classically both recognized both objective and subjective, that a big part of akathisia is the restlessness that patients complain about, sometimes out of proportion to the motor or objective measures. So that's true of akathisia. It's also true of tics, for example. You know, patients have this urgency to move in tics, and it's relieved by the tic itself. But whether tardive dyskinesia has subjective or affective symptoms is an interesting question. Many neurologists feel that another manifestation of tardive syndrome is pain and other other subjective symptoms. That's part of the picture. Certainly, patients with severe tardive dyskinesia, especially dystonia, patients find that to be very painful and emotionally, psychologically, and affectively disturbing. So if that's your question, whether affective or subjective symptoms are part of the dyskinesia, it's a very good question. And the feeling is that that is part of tardive dyskinesia. Conversely, if you're talking about people who have affective disorders, it's traditionally been felt that people with affective or mood disorders are actually at greater risk for having tardive dyskinesia, although I think that's confounded a little by the fact that patients with mood disorders are intermittently treated with antipsychotics. You know, they may get antipsychotics for acute depression or mania, and then they're stopped. And as I told you, the epidemiologic data indicates that people who have drug holidays or go on and off antipsychotics are at greater risk for TD. Also, the population of people with affective disorders is different than schizophrenics. They tend to be older and more females. And so there are other reasons why TD may be more common in bipolar or affective disorders, but that's certainly not immune from having tardive dyskinesia.
One last question, and I'm not going to take any more questions. So are you aware of any trials or studies on the augmentation of vitamin E with VMAT?
No, I'm not. You know, there'd be no harm in doing. There's no interaction I can think of why you couldn't do that. As I said, vitamin E is generally benign, although and some recent reviews suggest it is useful for tardive dyskinesia. I'm kind of biased the other way because a big study we did in people with chronic TD where vitamin E was no better than placebo. There's it's thought to be an antioxidant, and there's some thought that maybe vitamin E prevents TD from developing or getting worse, but there's no real data to support that, I think. So, you know, vitamin E is relatively harmless to try in patients who may not want to take other treatments. And I'm not aware of any data to suggest that it can't be used in combination with VMAT2 inhibitors. I may have to go. Maybe one last question or not. Yasir, I'll leave that up to you.
No, I think we're done with questions. Thank you very much for this wonderful presentation and for for being with us today. And this was really helpful for everybody. Thank you very much.
Thank you. It's an honor to participate. Thank you and goodbye.